What do you see in this hand? A thumb deformity. That is a classical extension of the pointing index along with the ape-like appearance because of the atrophy of the thenar eminence is a very classical feature of the median nerve palsy. It can also occur with leprosy, and also poliomyelitis is what you need to basically appreciate. Now you have been shown a ganglion. You need to identify which ganglion first. It is otic ganglion. So the otic ganglion relations is a favorite question of the examiner. Lateral to mandibular nerve, inferior to foramen veil, and lateral to tensor vellopilatini is the typical combination of the otic ganglion is what you need to basically remember. Now what is this guy doing? Blowing his cheeks. To blow the cheeks, what muscle is required? Masseter. Masseter is the muscle which is, buccinator is the muscle which is required. So what are all the things that pierce the buccinator? So lingual branch of the mandibular division of the trigeminal, parotid duct, and the mucous glands of the buccopharyngeal fascia, they are all the ones which basically pierce is what need to be remembered. Dr. Raman was bitten by his girlfriend on a romantic fit. So what is the nerve supply of the sensory supply of the ear lobule is the question. So you need to be very sure that the great auricular nerve, the lesser occipital nerve, the auricular branch of vagus nerve, and auricular temporal nerve. So answer should be D, because lesser occipital, great auricular, auricular branch of vagus, and auricular temporal, all of them supply but not the facial nerve, the ear lobule nerve supply. So is what you need to basically recognize. Now what is the diaphragmatic development? These are all contributing to the development of the diaphragm. Earlier question you are sure on the answer correction, right? So diaphragm development, what is accept? So basically diaphragm develops from pleuropericardium, body wall, and the septum transversum. They are all the things which are basically involved. Now you have been given the ECF and ICF. So fundamentally the total body water is divided into extracellular fluid and intercellular. And intracellular fluid is in turn divided into intercellular fluid, interstitial fluid, and the plasma volume. So interstitial fluid is around 12 liters, which is 80% of ECF. And intracellular fluid is about 25 liters, which is 40% of body weight. And extracellular fluid is 20% of the body weight and volume of 15 liters. And the total body water is 60% of the body weight. A 70 kg individual contain 60% of 70 kgs is 42 liters of total body water. Out of that, 25 liters is intercellular, 12 liters is interstitial. So you have been given to identify the fluid B. So B is obviously what? The interstitial fluid. And how can you calculate the interstitial fluid volume? Extracellular fluid volume minus plasma volume. So extracellular fluid volume is basically given by radioactive sodium, and plasma volume is indicated by radio-labeled albumin. By subtracting the radioactive albumin from the radioactive sodium, you will get what is called as the interstitial fluid volume, is what you have to be very clear about. Now what is total sodium in the body? It is around total sodium, if we take moles, number of moles, it is 5 moles mostly in the extracellular fluid. Okay, and you have been shown a life cycle. What is this life cycle of? Toxoplasma. And in the toxoplasma's life who is the definitive host where sexual function occur? It is the it is not the human. It is not the human. Cat is considered to be the definitive host, and most patients do not need the drug therapy with toxoplasma. Is a true statement out of all this. Infection occur by fecal-oral route is true. Oh, it is also there. Oh, I think B should be ideal answer, because infection does occur by fecal-oral route, and eye complications are very common. And I think we are missing on the part of except is a missing part. Okay. When we try to be too creative on creating a question, sometimes we miss a little English and grammar of it, but that makes significant difference. So except, please add up. Yeah. What is the life cycle? What is this infectious agent? Classically, Clark's sinuses. And what is least likely to cause the following, what is the least likely symptoms that can occur with clonorchis? So there can be, this is cystosoma, no, sorry. Meracidium, larvae, Sarcaria, and all these things are there, and Japanese female is standing there, and we could not recognize cystosoma japonicum. We are missing on the fact, right? So there is a reason. There can be itching, cutaneous papules, splenomegaly, portal hypertension, hematuria, hydronephrosis. There are all the possibilities which can occur with the cystosoma is what you need to basically remember. Now what is this? It is a gravid uterus of hydatid cyst, Echinococcus granulosus. So what is the, what was the question? Intermediate host. Intermediate host is typically sheep in the life of Echinococcus granulosus. Then which antibiotic is ineffective against the enterococci? Enterococci are like your streptococci, group D, streptococci, enterococci. So ceftazidime, cephalosporins, all enterococci universally are resistant to the cephalosporins is what you need to appreciate. Now various immunosuppressive drugs have been given. What is their mechanism of action? So let me once more vouch you, doctor, that one question is going to definitely come on immunosuppressive agents. You have to write in your 200 pages notebook and do a thorough revision. Right. So I think Siddiqui is being asking for fecal-oral route. So except is a small correction to be done. I am really happy to see 57 online viewers. So the time is, we are not really far away from the time where we will have 500-600 people sitting in the home and enjoying an online video discussion and also participating actively through the chat window, thanks to the technology. So cyclosporin is a calcineurin inhibitor. Azathioprine is a purine metabolism blocker. Sirolimus basically blocks the intracellular signaling. They're all the true statements is what you need to basically appreciate. Then, so you need to go, suppose if you did this question wrong, straight after going home, the 7 or 8 immunosuppressive agents you have to read. If you don't read once more, you will do the mistake in exam. That is very bad, right? So lot of students take our mock test. Every year about 80% of the top 100 rankers are our students, one or the other place. But another 2 to 3,000 people who took mock test also are there. But where are they? They didn't make it to top 100. Why? The main reason is every time you take mock test, you need to grab a set of topics for this week. Because these mock tests, every question we plan from the high yield topic list before we incorporate. So ultimately entrance also will have more or less 70-80% of the mixture of same topics of our mock test. Okay, doctor? So that should be the plan. A lot of people say, I'm not even crossing 100, I'm feeling tensed up in the mock test, what to do? That is the purpose of the mock test, to tense you thoroughly and alert you. Another 25 mock tests, every week 2 mock tests. So another 25 mock tests, you must improve all the areas where you are really missing and be ready and give a victorious hit to the examiner. So what form of immunotherapy has the most anti-tumor effect out of all the things being given? The most powerful would be interferon, is most consistent effect against the leukemias is what you need to appreciate. Then in which type of burn the papillary dermis is completely destroyed, from which level of burn onwards the papillary dermis is affected? First time when it is affected, which level it is? It is the full thickness burn, which is basically associated with the loss of the papillary dermis, is what you need to basically appreciate. Huh? Least burn depth, right? Deep partial thickness is the first time where papillary dermis involvement is seen. No? That least word is already there. Okay. I think B should be a corrected answer. Yeah. B is the corrected answer. So just somebody please make a note of what corrections we are making. At the end we will try to add it into our online question bank to do the correction. Now about the energy requirements. Typically a 60 kg sedentary man require about 1500 kilocalories per day. But it is the lipids which provide 9 kilocalories and carbohydrates is 4 kilocalories is what you have to basically understand. Now in rheumatoid arthritis, what do we use? We use ibuprofen. If there is a very severe significant deformity of the joint, we do arthroplasty and then we do arthrodesis, right, is what need to be remembered. Even our online student PG prep also is saying deep partial burns as a more validated answer for the earlier question. We do agree. Now doctor, regarding the gout, how do you treat gout? Gout is basically treated acutely by using colchicine and NSAID like indomethacin. Long term we use in the gout the allopurinol as the treatment. We have the buricase derivatives, the newer derivatives which are used to treat the hyperuricemia is what need to be remembered. So gout is treated by xanthine oxidase inhibitor is what need to be remembered. So there is no need at the time of acute attack of the gout for the presence of hyperuricemia. Uric acid level need not always be high for you to call it as a gout. During acute gout, from one level of uric acid to another level of uric acid, if there is a drastic fall, that also precipitates gout. So the gout is not defined, diagnosis is not defined by the absolute value of uric acid, is what you have to basically appreciate. Now doctor, overdosage of the local anesthetic, what will it basically cause? Depressed consciousness, circummoral paresthesias. You know very well that what is the mechanism of local anesthetic? They are all the sodium channel blockers fundamentally. Now which constituent has got the longest storage in the blood? Longest storage. RBCs last about 3 weeks, platelets last less than a day at 4 degrees but can be maintained up to 3 days. So by this logic, red cells are the ones which will longest survive. So once more, one question on blood transfusion. Every APPG entrance, there is one question on blood transfusion, even DNB exam. So you need to be quite sure. Then what is the most important nutrient for the enterocytes for them to survive? Glutamine is the one which is the constituent of most of the parenteral formulas which are used for the management. What is the usual liver transplant? How many anastomosis does it make? Around 5 anastomosis from the suprahepatic vena cava, intrahepatic vena cava, portal vein, hepatic artery, bile duct. In that order we do the anastomosis. Some of you are going to be MS general surgery, MCH gastroenterology and hepatobiliary surgery in a short period of time. Today morning only one of our student, Dr. Thirumal, he is from Kakatiya Medical College, Warangal. About 6 years back, he used to sit like this. He used to regularly ring and say that, sir, what is the answer for this question, that question? And so almost those days I used to have more time to spend with the students. So 1.5 to 2 hours also we used to talk about questions. He did MS general surgery and once more he topped MCS neurosurgery, and today he cleared his neurosurgery final exam. Now he is going to be consultant neurosurgeon. So I am very proud of some of the wonderful students like you. Once upon a time, today they are interventional cardiologists, some of them are consultant neurosurgeons, neurologists, etc. So that is the reason, doctor, that great dream that you are going to win, never lose that dream. That is the most important thing, doctor. Reading is secondary. To think big of yourself is the first thing to achieve, let me tell you. Automatically you will achieve. If not, you are the cream. You are the smartest people who crossed the filter at the MCET level or pre-PG, pre-UG level, no? So only thing is you need to just once more put yourself on that accelerating gear for at least 2-3 months, and by next April you're all running here and there with a blood transfusion bottle doing your post-graduation, and that is how the life should be. So doctor, the most common of the visceral injuries associated with the pelvic fracture would be urethral tear is what you need to remember, and that's the reason any pelvic fracture patient we should always evaluate for any possibility of urethral tear. Once more, extraperitoneal, intraperitoneal bladder rupture. How do you clinically differentiate? When you do the perrectal examination, a high-flying prostate is seen in which type of rupture? Similarly, difference between bulbar and membranous urethral injury. Today only after going home you read. Okay, definitely one question is definitely going to come. So doctor, with unstable pelvic fractures, when they bleed profusely into extraperitoneal space, the blood will track into retroperitoneal space, and there is a progressive hypotension. So what is the best way to stop the bleeding in such pelvic trauma when it is seeping into the retroperitoneal space? What you do is you will put an external fixator in the pelvis and try to fix it and stabilize a pelvic fracture is the way to basically stop the bleeding in case of pelvic fractures. Now what is this organ which is prolapsing? It is the rectal prolapse. So what is the blood supply of the rectum? So fundamentally it is supplied by superior rectal artery, middle rectal artery, median sacral artery are the typical things that you need to basically appreciate. Now there is a nerve injury with a sensory loss in the area. What is this area called? Regimental badge. Superintendent of Police, Inspector General of Police, they carry IPS, no? Regimental area overlying the deltoid. And also you can see the atrophy of the deltoid, which is classical of axillary nerve injury. So axillary nerve injury can occur in surgical neck of humerus fracture, dislocation of shoulder joint, or if you give a wrong and improper intramuscular injection is what you need to appreciate. So this is how the fracture of the surgical neck of humerus can impinge upon the axillary nerve and can lead to development of the axillary nerve injury is what you have to basically understand. Now coming to the tears of the rotator cuff, what is accept about it? generally rotator cuff tears will jeopardize the blood supply of the rotator cuff. That's the reason the rotator cuff injuries do not heal that easily, because of a poor blood supply is what you have to basically appreciate. Now coming to the fracture of the clavicle, it is usually seen on the lateral midshaft. If you divide the clavicle into 3 1/3, lateral 1/3 and middle 1/3 junction is the point where there is most commonly the fracture of the clavicle is what need to be remembered. Huh? Clavicle fractures junction of the lateral third and medial 2/3. Yeah. Option C. Usually need no reduction. Put a bandage. What is meant by reduction? Closure reduction. You will basically give some sort of a anesthetic sometimes, and then without incising you will try to do the reduction, like you do the reduction of shoulder dislocation. No, nothing is done. Put a plaster. Take rest, watch 2020 cricket match, luckily if it is running, and take vitamin D, calcium tablets, and first 8 to 10 days very painful clavicle fracture. My younger son is the most naughty guy and he had a clavicle fracture. So first 8 to 10 days, with the pain is so much that he used to get pupillary dilatation. I used to fear, is this clavicle is injuring spinal cord, is the spinal cord injury is causing effect on the almost 20 to 30 orthopedic surgeons that I ever know. I gave a call, some of them are our faculty also. They said, oh come on Murli, don't be so timid. After all, it's a fracture that heals. So it healed, and after going to school he has shown to all the girls in the class, see I had a fracture, I am the very strong boy in the class. So that should be so clavicle fracture generally doesn't require the what you call any reduction at all is what need to be remembered. Now what kind of pupil is this? Meiosis. So which is a meiotic out of this? Timolol, which is a which is a beta blocker, is a cocaine, epinephrine, amphetamine. Cocaine is meiotic or mydriatic? Oh, sorry, I think I missed that point in the rush. We need to change the option B. Okay. Option B also we need to alter. Okay. Then 53-year-old women with CNS Sarcoidosis. This is a little challenging question. She had no visual symptoms. There is a relative afferent pupillary defect. MRI is being shown to you. What is the MRI showing? The neurosarcoid is compressing the which part? Optic tract. And because of that optic tract lesion, what kind of visual defect will come? Incongruous left hemianopia. The more peripheral is the lesions, the visual field defect will be incongruous. The more central the lesion, the vision defects will be more congruous. And similarly, whenever there is an involvement of occipital lobe, there will be a macular sparing, right? So there are few things, but if you did this question wrong, what will you do? Totally 9 visual field defects at the level of retina, optic nerve, optic chiasma, optic tract, lateral geniculate body, then optic radiation and occipital cortex. Where do you get superior and inferior quadrant anopsia, macular sparing, macular involving? That list is there na? Without that there is no question of imagining MD entrance. If you didn't read and go, it is our problem, not examiner's problem. He will definitely give it. Okay. So that's the reason, please make it sure that you will do this correct. Then if you have done this question also wrong, you are thoroughly validated that you need to go back and revise it. Okay. So what is this fundamentally? So whenever lateral geniculate nucleus is there, then typically you have a visual defect which has got a meridional cut, as what you can see here, along the horizontal meridian. Then what is this ocular condition? Where the eye is rolled inward and upward, and patient has a difficulty and get diplopia when he looks down. Classical of trochlear nerve injury leading to superior oblique paralysis is what you have to basically appreciate. So there's a diplopia, the eye deviates upwards and inwards, patient has a difficulty to walk down the stairs is a classical feature. So there are few image based questions, doctor.